diagrammatic representation of your normal digestive system. You had a lecture on development of GIT yesterday, was it? No. You had it. Alright. So when we talk about congenital, alright, we're talking about congenital anomalies, and there are various nomenclatures for anomalies. I'm not sure whether this has been mentioned to you. When we mention its malformation, it occurs during the formation, either complete or partial absence of a certain structure, right? And then disruption is an alteration after the structures has already formed, right? Due to either drugs, teratogenic drugs, chemicals, exposures. Okay. Deformations are due to mechanical forces over a prolonged period of time. It is not a destructive process. To defer it, it is some sort of like a space or external force. For example, you have your clubfoot, you have amniotic band syndromes, right? And a group of anomalies which is occurring together, and some of them might have specific genetics predisposition, are the one we call syndromes, right? So when it is a syndrome and the common or the specific etiology is known, then the risk of recurrence can be calculated, right? So sorry that this morning I had a malware, tak tahu dari mana. We're going to touch a bit on congenital anomalies of the GIT. You had lectures on colorectal disorders, liver and biliary disorders, pancreatic disorders by the surgeons. Right? Do they mention congenital disorders?
Not really.
Not at all.
Sikit.
What are the things that they mention?
Macros diverticulum.
Sorry?
Macros diverticulum.
Macros diverticulum lagi?
Biliary atresia.
Huh?
Atresia.
Pancreatic divisum. Anything else?
Tracheoesophageal
Annular
fistula.
pancreas. Lagi?
Tracheoesophageal fistula.
Pancreas je ingat.
Tracheoesophageal fistula.
Esophageal fistula. Okay.
Alamak bergerak.
Out of all the congenital anomalies of the gastrointestinal tract or hepatobiliary included with it, right? The anomalies of the intestines are among the common ones, right? But I'm surprised that you mentioned all the pancreatic anomalies first. Agaknya lecturer siapa kan pancreatic?
Alamak Azrin.
Alright, so we're gonna start. Okay, we're gonna start up from the opening, which is your mouth. Then we have cleft palate. It is due to hypophagia of your mesenchyma, or mainly the failure of fusion of the medial nasal and maxillary process. So it's on the upper part of the mouth. You can never see cleft palate on the bottom lips. Cleft lips. So the incident is not that rare. It's 1 in 700. You see, 1 in 700, we have deliveries in a month about 700 to 800. So maknanya every month you are going to have 1 or 2 babies with cleft lip. Alright, they are sporadic. Okay, tak ada kena-mengena dengan old folks tale. But some of them are genetics predispositions, such as your the Van der Waals syndrome, right? And most of them are part of syndrome malformation complex. Right, you have various syndromes, and also some external factors such as maternal smoking, alcohol, anticonvulsants. These factors are actually, I'm going to just mention it once, right? Because these factors actually causes most of the congenital anomalies. Okay, what you find in cleft lip is a small notch at the vermian border, okay, involving the skin, muscle, and also mucosa. It can be unilateral, right, or bilateral. Okay. Apart from cleft lip, you can have an association with cleft palate, right, which due to failure of palatal shelf to fuse. Cleft palate is a little bit more rare. It is like about 1 in 2,500 live birth. Right, can be isolated or in addition with cleft lip. Right, it can either involve the inner part, okay, which is your uvula and your soft palate, or it can extend all the way to your hard palate, right, and also your cleft lip. Okay, the problem with this oral malformation is with feeding, and you can see, you know that newborns, right, establishment of feeding is very important. Okay, so how do you establish feeding? How do you establish feeding? Or why can't they feed in the first place?
Sebab tak tertutup.
Because of difficulty in suckling. Why?
Pressure dia tak tertutup, tak boleh suck.
Right, because of the seal and we call it latching. Right, when the babies cannot latch properly, there would be no suction effect, and there would not be effective sucking. Right. So, however, the correction depends on the degree of deformity. But usually in cleft palate, it is performed before 1 year of age, or before your first dentition, or before the first expected words. Right? You can't expect the child to articulate or speak if you do not repair. But for cleft lip, which is a little bit simpler, so the closure can be done completely by the age of 3 months. Okay? So these are the ways, various ways of feeding. Right? You have special teats for cleft lip and also cleft palate. Let me go down to your esophagus. The most common one is esophageal atresia, but most of this esophageal atresia is associated with tracheoesophageal fistula, right? And being the commonest one is a blind pouch with the fistula connected to the distal esophagus, which is the C type, right? Okay. And again, some of them are part of syndromes, and the main concern, or our main concern, is recurrent pneumonias due to regurgitation and aspiration. But if you look at the types of esophageal atresia and tracheoesophageal fistulas, which are the types that frequently cause pneumonia and aspiration?
D.
C.
D-E.
Kenapa D?
D-E.
D.
E.
B.
The
E
ones
pun
that have
sama.
connection with your alimentary tract and your respiratory tract always cause an aspiration, right? And the one with blind pouch, the proximal blind pouch, usually they come with frothy or bubbly secretions, even at birth. Okay, and however, they are not at risk of aspiration as much. Okay? And even if they aspirated the upper part of the respiratory secretion, which is in the commonest type, which is type C, okay, the complication is not as bad as when you aspirate your gastric content. So the later types, D and E, tend to have severe or more severe aspiration, and they tend to be misdiagnosed, late diagnosed in type E. Okay, the diagnosis is mainly, remember when I say more than almost 90%, 80% is the one with type C, with the proximal blind pouch. So diagnosis can easily be made at birth when you are enabled to pass a nasogastric tube, and you can see that the nasogastric tube coil on X-ray. Right? It goes up back. Right? And then when these are the H type, which you might miss at birth, right? Patient can still eat, patient can still breathe, but there is connection between their trachea and esophagus. So this type can easily be seen sometimes when they do bronchoscopy or endoscopy by injecting methylene blue. So the management is basically prone positioning, esophageal functioning, but actually the ultimate or definitive management would still be surgery. Right? Surgery is comprised of end-to-end anastomosis. Right? However, if the gap is very big, then you have to actually resect some of the segments, either the gastric segment, jejunal or your colonic segment, to be created as a new esophagus. Okay. But some of the complication of this end-to-end anastomosis can be refistulization and recreated fistula at the adjacent to the surgery site or anastomotic strictures. Okay, then you have your hypertrophic pyloric stenosis in your stomach. Right, the incidence is also quite common, right? 1 in 1,000, and this is usually seen in male. Okay. Some of them are associated with certain syndromes. So when we talk about congenital anomalies, you will not run away from all these syndromes. Okay. It is due to the abnormal muscle innervation, elevated serum prostaglandin, and also the increase in gastrin secretion. So I hope you know where your pylorus is. Right. The features of hypertrophic pyloric stenosis, the name implies that it doesn't only involve stenosis. Right, you have elongated and hypertrophic pyloric muscle, so you have your elongated pylorus, right, and hypertrophic, and also your stenotic segment. Okay. So the classical presentation is that they present with non-bilious vomiting. Right, please remember, it is a non-bilious vomiting. Even knowing your anatomy, you will know that the vomiting is forceful following feeding once the stomach is distended, and it is non-bilious because it is proximal to your biliary opening in the GI, right? Usually it presents at 3 weeks of life. Doesn't really present at birth, okay, because the muscle need time to become hypertrophic and the orifice becomes stenotic. Okay, so what the child would present is with recurrent vomiting following feeding. When he already vomits out everything that goes inside, then the child or the baby would feel hungry again. So, but the concern is the amount of fluid loss, hydrogen ions and chloride loss, okay, which can actually cause severe dehydration and hypochloremic metabolic alkalosis findings on your lab investigation. You also have syndromes associated with congenital hyperbilirubinemia. So on examination, you can see, you can have firm olive-shaped mass, movable because this is bowel in origin. It is not stick to any structures, right? Okay. You can even see the shape. Why is it oval? Because of the elongated pylorus. Okay, extending from the above left to the down right. Okay, and you can even see gastric peristalsis movement, right? And confirm, and majority of the cases can be easily diagnosed by ultrasound by just measuring the pylorus segment and also the thickness of the muscle. However, if ultrasound fail to diagnose, what would happen when you do barium swallow, right? The picture would just be the same as the diagrammatic representation. You have pylorus, elongated part of your pylorus, right? And then you have the shoulder sign, bulging of your pylorus into your antrum, see the shoulder sign, and also the stenotic part or the double track sign. Okay. The management will involve correction of the fluids and also electrolyte imbalance and also surgery, right? But in less severe cases, endoscopic balloon dilatation can be attempted. Okay. And next you have your hiatal hernia. I'm not going to talk about diaphragmatic hernia because there are many types of hernia, but the ones I'm going to touch is just on your GI system, because diaphragmatic hernia involves the failure of development of the diaphragm. Okay, it's not failure of the development of the GI tract. The GI tract is normal, right? But hiatal hernia is the weakness, the part of weakness on the upper part of the stomach, and also sliding of the fundus of the stomach when you have correction done. Right, so the first type is actually associated with gastroesophageal reflux and weakening of the sphincter. Okay, so the manifestation mainly reflux and also early satiety or upper abdominal pain in bigger child. Okay. So in less severe cases, you only need medical treatment for the reflux, right? But in more severe cases, for example, the paraesophageal hernia, right, you need surgical correction. Then we go down straight to your duodenal. Duodenal atresia is among the most common intestinal atresia. You can have jejunal, you can have ileal atresia, but then the most common intestinal atresia is your duodenal. The incident is not that common, even though I said it is the commonest intestinal atresia, but in overall, atretic bowels are not common. Right, so it is just only failure of recanalization of your intestinal lumen, and this is mainly associated. What is trisomy 21?
Down
Syndrome, right? So you can have either presence of membrane obstructing, complete membrane obstructing the lumen, or you can have fibrous band connecting to blind pouches, or you can even have an absolute gap. Right? But all of them cause intestinal obstruction, definitely. Okay, so having known that they cause a complete intestinal obstruction, so the presentation is mainly at the first day of life. They couldn't see. They have bilious vomiting, right? That is how to differentiate from your pyloric stenosis. Right? This one presents very early. They present with very a lot of bilious vomiting, but then still you can see peristaltic movement, and it is associated with jaundice in 1/3 of the cases. So this is a classical appearance on X-ray where you have double bubble, right? So when you look at the previous diagrammatic representation of the defect, it just looks the same of what you can find in X-ray. Okay, so the management would be decompression of the proximal part, right? Correct any fluid and electrolyte imbalance secondary to all the vomitings, and also the definitive one is to anastomose the two blind pouch. Then you have Michael's diverticulum. Since you have this, I'm not going to touch much actually. It's just a remnant of your omphallomesenteric duct or your Vitelline duct, okay, which initially connects the yolk sac and the intestine, but it should regress, right? So the rules of 2, I'm not sure it's mentioned to you, but this is the famous rule of 2 for Michael's diverticulum, right? 2% of all infants, by second year of life, right? 2% of those are symptomatic. Okay? Not many of them are symptomatic. Usually it's 2 inches long and 2 feet proximal from ileocecal valve. Right? What causes the symptoms is that majority have an ectopic mucosa which also secretes, and it's something like what your gastric mucosa secretes, right? So then it causes ulceration and also sometimes rectal bleeding. So due to the ulceration and inflammation that the patient presents with something mimicking like an acute appendicitis. Okay. And the treatment is just surgical excision of that part. We go down to your colon. We have Hirschsprung disease, congenital aganglionic megacolon. Right? This is the most common cause of lower GI obstruction in neonates. Right? Again, it is more common in male. So when you have an absent ganglion cells in the submucosal and mesenteric plexus, you have failure of relaxation of that part. See, please don't confused. If you have aganglionic, that segment doesn't go dilated, right? That segment goes contracted. There is failure of relaxation. So the distal part would be distended. The part which is abnormal would be collapsed or constricted, and then hence you have collapsed rectum, right? And also tight internal anal sphincter. So you have the short segment and long segment type of Hirschsprung disease, and the short segment is more common, hence the complication is less, right? Whereas in certain cases you have long segment, then the complication or the surgical management is much more difficult, right? They present with failure to pass meconium. Knowing the anatomy and the defect just now, you can just figure out the manifestation. So they fail to pass meconium because you have a constricted distal part tadi kan, right? Then they have the distended proximal part, sometimes up to bilious vomiting. However, older children may also present with chronic constipation, right? You need a lot of amount of stool to push down through the constricted part, right? So they only have bowel opening like once in a week, and the stool tends to be very hard. Okay, and then failure to actually propel the feces out can eventually lead to stasis, and sometimes they end up with enterocolitis or sepsis due to the bacterial overgrowth. Okay. So on examination, you can see a lot of fecal mass. This happens in all other causes of constipation as well, but the hallmark is empty rectum on PR. You have a gushing of gas, right? The moment you open the collapsed part with your finger, right, you have gushing of air or even gushing of feces as well. But the diagnosis, it has to be made by rectal biopsy, and the treatment is by surgical, removing the aganglionic part or the abnormal part. Then you have malrotation, failure of the bowel to rotate. It is associated with a lot of other abnormalities of the gut, formation of the gut, right? But most common type is when the cecum fails to move to the right side of the quadrant. Okay, this is where your cecum should be, but from there dia turun sini. Okay, but when the cecum fails to move, the left band would eventually strangulate the duodenum. It can cause strangulation, it can cause valvulus to the duodenum or the proximal part of your small bowel, right, around your small mesenteric artery. Okay. They usually present very early, within first 1 month of life, with bilious vomiting, tender abdomen, all the signs of intestinal obstruction. Okay. And contrast study